Dr. Jeffrey, I'll now ask you to introduce our special guest this morning, the Minister of Health, the Honorable Paul Merriman, and the Minister of Mental Health and Addictions, Seniors and Rural and Remote Health, the Honorable Everett Hindley.
Thank you. So it's my pleasure today to introduce our two ministers who are visiting. So Minister of Health, Mr. Paul Merriman, was first elected to the legislature back in 2011 and re-elected in 2016. And I'm pleased to say he's my MLA in Saskatoon and Silver Springs. He served as Minister of Social Services, Government House Leader, Deputy Government House Leader, Government Whip, and then in November 2020, Premier Scott Moe appointed him as Minister of Health. We also have with us today the Minister of Mental Health and Addictions, Seniors and Rural and Remote Health, Mr. Everett Hindley. Mr. Hindley was first elected as an MLA for Swift Current back in 2018. He was re-elected in 2020. He also, way back in 2007, was the executive assistant for the Premier. In November 2020, Premier Scott Moe also appointed him as Minister of Mental Health, Addictions, Seniors, Rural and Remote Health. Welcome, ministers, to the Representative Assembly, and we look forward to hearing from you and asking some questions as well. Ministers.
Whichever one you like.
Great. We're good. Good morning, everyone, and thank you very much for including Minister Hindley and I. This is our first RA that we've been able to attend in person, as the last two were both done virtually. Thank you very much, Dr. Jeffrey, for your kind words and working relationship that we do have and that we continue to have with the SMA, with both the board and the executive team. Very much appreciated. Well, I've already said that thanks to Dr. Jeffrey, so we'll skip that. This summer, Minister Hindley and myself were traveling to all points of the province. I think Minister Hindley was as far north as Black Lake, and traveling across, talking to physicians, talking to frontline healthcare workers, and visiting facilities to see what it is that we could do. And a lot of the people that we met with, doctors, frontline healthcare providers, provided us with very direct feedback on where it is that there were gaps in the system, what was working, and what we needed to move forward on, and the challenges that that they were facing on a daily basis. What we heard consistently was we need more people. We need more people across our province. We need people in specific areas. Minister Hindley in Rural and Remote had service disruptions across the province, which I'm sure you're all very aware of. Some of those have come back online, and we've been able to get some services back up and running. But throughout these tours, we had a great opportunity to be able to sit down and chat with people just in the coffee rooms when they had time, understanding we didn't want to disrupt their services because they were very busy, whether they were in their ERs or in their long-term care attending to their patients. We wanted to make sure that we had an opportunity to talk to frontline healthcare workers. I want to talk a little bit about the Ministry of Health, and we have our new, and I want to congratulate Andrew Will on becoming the permanent CEO for the Saskatchewan Health Authority. Andrew has taken on a huge role in working with all of our former health regions in all corners of the province. Most of you know Andrew. He has been within the system for a while, and it's very nice to finally have a permanent person in there that we can make sure that is going to be looking out and working for it. One of the things that was tasked to Andrew via the board was to work with the SMA and work with the board to be able to work on the bylaws and some of the other concerns that they had brought forward. So I wanted to thank Andrew for that and congratulate you on your appointment, Andrew. We're also remaining committed to working with the SMA to develop primary care compensation models that aligns with the province's connected care strategy. At the spring SMA RA, we also heard concerns about the health human resources. We have since announced our health human resources 4-point plan, which Dr. Jeffrey touched on to recruit, train, incentivize, and retain our healthcare workers. This investment was over $60 million, add more than 1,000 healthcare workers over the next few years to be able to stabilize our healthcare system. Our efforts will build on existing initiatives and incentives that we had in place to recruit and retain physicians specifically. This year's budget, we added $3.5 million for targeted programming to support recruitment and retention for more physicians. This includes training more doctors at home in Saskatchewan. To support training and retaining physicians, residency seats at the College of Medicine has also been expanded by 8 for a total of 128. And I also want to thank Dr. Preston Smith, who's here today, for all of his hard work in working with us in advanced education and also helping inform me and having some very candid conversations. So thank you very much, Dr. Smith, for your advice and your sage timing on helping me out whenever I need some advice on how to work through the process. So thank you for that. This also includes expanding intake for Saskatchewan International Physician Practice, our SIPA seats, to 45 per year, enhancing our rural practice for physicians. We're also committed to working with the SMA to develop a shared understanding of key priorities for physicians in the healthcare system. In the coming months, we will continue to aggressively promote career opportunities within our healthcare workforce. An example of that, we are actively exploring opportunities for physician assistants, which again was brought to me by Dr. Smith, positions in Saskatchewan, and we're actively working on this to see how we can support our doctors and our healthcare workers. Initial conversations are very positive and suggest that we may add significant value to this to our healthcare workers, both for the patient's perspective and the physicians. Please continue to spread the word about these important initiatives and the benefits of joining our healthcare teams in Saskatchewan. And I want to thank you for your dedication and your hard work over the past 2 years during the pandemic. And now that we are in an endemic phase, thank you very much for keeping our healthcare system stable. Minister Henley.
Thanks, Minister Merriman. And just to follow up on what Paul said, thanks to everyone for being here today and for everything that you do each and every day for our healthcare system. It's so vital to what we're trying to do as a government and as a province here to take care of all of our people in our province. I'm pleased to also be here and to join in offering congratulations to Dr. Jeffrey on his first SMA RA in the role as the SMA president. As Minister Merriman mentioned, during our healthcare tours this summer across the province, we heard directly from healthcare workers, frontline workers right across this province. And one of those things that we heard is that there was a requirement and a need for more permanent full-time positions right across a growing Saskatchewan. And although we're in the early stages of this very aggressive recruitment and retention plan, we're starting to see some momentum and seeing some quick wins, I think, but there's obviously a long ways to go. The SHA is actively recruiting both nationally within our country, but also internationally as well, through a number of channels to help promote some of these opportunities here in Saskatchewan. Earlier this month, you probably heard that we announced that more than 175 new full-time healthcare job opportunities were posted to help address some of the rural and remote staffing challenges. We're also committed to supporting and maintaining a continuum of mental health and addiction services to support individuals and families right across our province. As an example, the government of Saskatchewan and the Atakaku Cree Nation recently signed a memorandum of understanding to advance a new approach in the development of a new urgent care center in Saskatoon. This urgent care center will offer Saskatoon residents an alternative to emergency departments for illnesses and injuries that aren't life-threatening, as well as mental health supports. New funding in this year's budget will increase the number of specialty and family medicine residency training seats and also nursing training seats as well. And this year's $3.5 million additional investment in physician recruitment and retention that Minister Merriman touched on will particularly target family physicians working in rural and remote areas of the province. As an example, in addition to our family medicine training sites in Prince Albert, Swift Current, La Ronge, North Battleford, and Moose Jaw, medical residents are now able to obtain training in multiple sites in the areas of Southeast Saskatchewan. We believe that increasing these rural training opportunities helps us to recruit more local physicians to rural communities. We're expanding the SIPA program, which includes added supervision and also supports for physicians following their assessment. And we're also currently looking at ways to strengthen and enhance the rural family physician incentive program to encourage recruitment and longer-term retention in rural Saskatchewan. The planning has begun to establish a new independent agency dedicated to the recruitment of all health professionals in our province. The Saskatchewan Healthcare Recruitment Agency will help attract the human resources required with a focus on addressing challenges in rural areas. And I'm pleased to say that as of today, we've now posted for the CEO position for this agency. And it's important that we get this work done quickly. By offering competitive incentive packages and focusing on key recruitment and retention practices, we'll be able to attract more health professionals to practice in the communities where they are most needed. And that includes family physicians and other specialists as well. We'll also continue to promote Saskatchewan as a great place where you can have a successful and rewarding health career and be part of a strong, supportive community, but we're going to need your help to be able to do that as well. And with that, we're very pleased to be here today to provide a bit of an update on the status of healthcare in Saskatchewan and be willing to take any questions about that you might have. Thanks once again.
Ministers, thank you very much. The ministers have graciously allowed time to receive questions from RA delegates. Please remember, once you're invited to speak, please speak loudly and clearly and be brief with your question to enable all interested delegates the opportunity to ask a question. You will have 2 minutes to ask your question, and please refer to the timer. Please also remember that the non-RA delegate microphone is located here to my left on the right side of the room. Delegates are representing larger bodies of physicians, and so delegates will have precedence if there is a longer line at the microphones. Thank you again, ministers. Can I come to microphone 2 first, please?
Hello, hello. Hi, I'm John Dosman. I'm a family doctor in Saskatoon. I just have an ask around syphilis testing. It's gotten pretty crazy. Syphilis has gone from something we learned in medical school about as a historical disease about Vincent van Gogh cutting his ear off to something we now see very regularly. I think there was just over 100 cases in 2017, and last year there was 1,700, and the real problem is congenital syphilis. So I also deliver babies. Trying to coordinate treatment and follow-up is really difficult. Right now, testing has to go to the provincial lab in Regina with a turnaround time of 3 or 4 days sometimes. So we're struggling to make decisions on how to risk assess people. And so we're talking with our PEDS ID colleagues, we're talking with the obstetricians. Sometimes we're making the wrong decision. We're sending people home that we think are low risk, only to have results come back later showing that people have syphilis, and then we're scrambling to try to get them back admitted to hospital for treatment. Just this week, our 6-person call group, we have 2 babies admitted into NICU for treatment for congenital syphilis. So it's getting worse and worse. I know trying to figure out how to solve this, I've been talking with various people, and even our lab colleagues, they say in Saskatoon, they have the resources and the equipment and everything's ready to go. We just need, I guess, funding to make that happen. So I'm asking if you can make that happen. Thanks.
Sure. Sorry, just your last point there. What was that you're waiting for happen in the Saskatoon labs?
Funding.
Just funding?
Yeah.
Okay.
Yeah, I think there's been a proposal put forth to the ministry, and it's just waiting for it to happen.
And obviously that would speed up the process for being.
Yeah, the turnaround time
detection.
turnaround time would be a day or 2. And then people would still be in hospital, and we'd be able to, especially with the babies, be able to make decisions better.
And sorry, I don't want to get too much into what's the funding request? Do you know what the dollar amount was on that? Okay. How about we'll look into the funding of that, and I understand that would certainly speed up the process and certainly help with the diagnosis, because then you've got to get them, find them back, pull them back into the system to be able to treat them properly. and forgive my not understanding this, is there an option that there is an interim treatment that you can give until the lab work comes back? Like, I don't
Well,
know that.
that's kind of what we're doing right now. We're making
Okay.
our best guess based on,
Symptoms.
mums, what their blood work has been previously, if
Okay.
they've had treatment, how many treatments they've had. It's a bit of a complex algorithm. And so we're making our best guesses. And so like the two babies that we have admitted right now, that's based on deeming it a medium or higher risk situation. So we're starting treatment
Okay.
before getting some of these results. Yeah.
And sorry, that was what?
Yeah,
Right.
the babies are in
Right.
there for 10 days, yeah.
Hmm.
And conversely, sometimes we're not sure, so we're asking moms and babies to stay in hospital for up to 4 days where they might not need to, waiting for results
Right.
to come back.
Okay.
Yeah.
I don't have that specific funding request in front of me. I'm not familiar with it, but I could certainly pull it up and get it on my next briefing for next time. I don't know if anybody. Okay, we'll have to follow up on that. I'm not sure that specific one, but I'll tell you, it makes sense to me. I just got to look at the dollars and cents and see where it is. But thanks for bringing that forward. That's a good process improvement for us.
Thank you. Before I take the question from microphone number 1, I see that stealthily and secretly 3 people have joined us on stage. Would you guys like to grab the mic and introduce yourselves? Lovely to have you. Lovely to have you. But I don't want you to be anonymous. Please go ahead and introduce yourselves.
Thank you very much. It's a pleasure to be here. I'm Tracy Smith, the Deputy Minister of Health, and this is my first RA as well. So it's great to look out and see so many faces. And again, just appreciate being here. Thank you. Oh, you got one there? Okay.
It's on. So good morning. I'm Norman O'Neill, also with the ministry. I'm the Assistant Deputy Minister with responsibilities for Medical Services Branch.
Good morning, folks. I'm James Turner. I'm the Executive Director of Medical Services Branch at the Ministry of Health, and so I'll probably be the one following up on your questions today.
Thank you. Thank you for joining us, and thank you for the work you're doing to help answer the questions and move these policies forward. Can I go over to microphone number 1, please?
Good morning. I'm Brianna Davis. I'm a delegate from North Central MSA. I'm a family physician in Prince Albert. As a family physician who is in a community that's very short of family physicians, I'm very excited to hear about plans for recruitment and retention and training. But as a teacher, this exhausts me. Already, I could be teaching a medical student, and I have 3 residents, a nurse practitioner, SIPA grads. I feel like teachers are also a bit burnt out. And so I'm just wondering if part of the plan is how we're going to accommodate all of these 1,000 workers, because they each will require some form of education, orientation, supervision. So I just am wondering if that is built into the plan.
It's an absolute great question. And when we bring in more workers, there is more time pulling from the experienced clinicians out there to be able to give their time to be able to teach either the Saskatchewan system or / the Canadian Saskatchewan system. One of the things that we're doing certainly with our RNs is we've reduced the bridging time from our RNs. It used to be 9 months, I believe. We've reduced that, and we're actually getting most of the bridging done in the Philippines for some of our new Filipino workers. With as far as that, as your specific question, I guess I would want to know, what is the ask from, like, I know you're getting burnt out. Is it a time that you can't split between your seeing your patients and mentoring this individual? Is it a dollar amount? What is it that, or do we just need more people that would pull into the system to be able to mentor?
I think this is maybe one of the only questions that isn't really a dollar amount. I don't know if you could pay me any more money. I don't have space or capacity even to take more students.
Okay.
And I look around and I feel like everyone who could be training is training. So I mean, I just think that if we're bringing in 1,000 new people, I just don't know who's going to train them. And the same for lab techs and RNs. We're so short of frontline staff. And those are also our teachers. So I guess it's a bit more complicated than a dollar amount. And I'm not sure that just reducing the amount of training is an answer either, because then we're putting less prepared healthcare workers into the workforce, which doesn't necessarily translate into more help.
Yeah, understanding that there are going to be some certainly short-term stress on the system when we're bringing more people in, but the reason we're bringing more people in is to take pressure off the system in the mid to longer term. And these 1,000 workers aren't going to just drop into the system overnight. This is over the next couple of years. We're bringing in cohorts. We're working with the College of Medicine to be able to make sure that we're integrating them into the best way possible. And Tracy just gave me an update that the SHA is developing a new mentorship program, an additional peer-to-peer well-being and resiliency program. So we are in the process of developing that, because understanding that does put more pressure on the existing physicians out there to be mentoring. So we're working on that. We'll include the SMA in that process to be able to make sure that it does work, because sometimes when we develop a policy, we want to make sure that it works when the rubber hits the road. So we're going to try to develop more teachers if we can. But again, I want to make sure that we're not just we want to have qualified teachers to make sure that the patient is safe at the end of the day. I don't want to bring 1,000 people into the system if it's not going to be safe for the patients. So we will stage this out as much as we possibly can.
Thank you.
Thank you. Please, can I come to microphone 2?
Absolutely. Peter Butt, I'm chair of the addiction medicine section, and I'd like to thank you for coming and taking our questions. The issue here, frankly, is a very broken system of care for people that are struggling with substance use disorder. If we think about what's required, 3 to 12 months of non-use, no negative consequences is what we call early remission when it comes to a substance use disorder or addiction. Over 12 months is sustained remission. What do we offer people? We offer them perhaps 7 to 10 days of detox. They might have access to a traditional bed, and then they have 28 days. None of this is necessarily evidence-based. None of it necessarily has continuity of care attached to it. And if you do the math, it isn't even providing people support to get into early remission. Now, when it comes to cancer care, we don't think twice about providing care until they're in remission, if it's at all possible. However, it seems to me that with addiction medicine, we're in a situation where people are not getting the support that they need. It's not evidence-based. It's not a coherent, recovery-oriented system of care that has continuity from prevention to harm reduction, outreach and engagement, all the way through to treatment and recovery support. So if people get better, it seems to me that more often than not, it's despite us in the system rather than because of what we have to offer. Consequently, we're seeing more deaths each and every year, particularly from opioids, but also from a combination of substances. So the question is, do you have a vision? Do we have a plan for a recovery-oriented system of care that's evidence-based and coherent that we can present to people so they know how to navigate it? Or are we going to continue with sort of episodic points of investment that really aren't coherent overall?
Thanks for the question, Doctor. Yeah, and it's a great point, and it's something that we're working towards as a better overall, more comprehensive plan. Because you're right, there's several components to this, right? There's prevention, there's treatment, detox, recovery, and then there's the post-treatment phase as well. And what we're working towards and what we're striving to try to achieve here is this shift from the old 28-day model of treating addictions, which we all know, and I've heard it loud and clear from professionals I've talked to, those that are in treatment facilities, that just, it doesn't work, it doesn't cut it anymore. So we have to look at different ways that we're doing this. It's why we're doing things like the treatment center in Estevan, where I think they've treated over 200, close to 250 individuals thus far. The youth treatment facility in Swift Current there, that's accepted about 20 youth it's provided treatment to in the past year. One of the things I do hear regularly, though, is about the post-treatment and what happens to an individual when they've completed treatment, whether it's 50 days or 150 days days or whatever the number might be, when they leave that facility, how do we ensure that they're properly supported, that they don't end up perhaps in the back in the same scenario that got, them into an addiction challenge in the first place. So we're looking right now at how we can better support that. We recently closed an RFP here in early September as part of our commitment to add 150 more treatment spaces in the province over the next 3 years. We have a couple $2 million in this year's budget to get the first number of those beds and spaces operational. I'm expecting some recommendations from our officials very shortly in terms of what that might look like for this year, and wanting to get those now. I've had the opportunity to tour a number of these, whether it's, as an example, Prairie Sky Recovery in Leipzig in West Central Saskatchewan. I toured the new Pine Lodge facility here in Regina earlier this week. I had a great tour there with CEO Andrew Love, and we had a very good conversation about what needs to be done around this space. But to your point about having a more comprehensive system, that's the goal. We need to make sure that we have a system that people understand, that they don't have trouble navigating as a patient and as a healthcare provider in that system. And we'd appreciate any sort of advice or support that you might be able to provide in that regard to help us flesh that out.
Sure. be
Thank
happy
you.
to further
We'll
the
go back to
conversation.
microphone number 1, Dr. Butt. Before I go to microphone number 1, though, let me offer a word of apology and a word of encouragement to anyone who's using the non-delegate microphone. As you see, there are delegates, and I do have to give them precedence, but hang in there. And I also appreciate people who are coming up to the microphones and distributing themselves evenly in the lines. Makes it easier for me. Microphone number 1, please.
Good morning, everyone. I'm Dr. Barb Konstantinovich. I am the section president of family medicine, past president of the SMA. Welcome to the 2 ministers and their staff. Community care, community medical care is the vast majority of care that most people will experience during their lives. Institutional care, it basically comprises of a small amount of the care that people will have over the course of their lives. Institutional care has received a large proportion of supports, but community care is lacking. Every area of healthcare impacts on family physicians. If there's an advancement in one area, or if there is a need to have family physicians follow up, it falls on the shoulders of family physicians. We're always scrambling to do best practice and follow the new standards and guidelines. I know you've talked about retention and you've talked about recruitment. I would really like stability. I've practiced here for nearly 40 years. And in that 40 years time, I've seen instability. I think the people of Saskatchewan, the voters of Saskatchewan, our patients in Saskatchewan, our families deserve some degree of stability. And since community care is such a vital and important part, will you commit to providing more resources to community care? Thank you.
Thank you very much. And it's a very, very good question. And thanks for your time on the SMA board. As I do appreciate that. The stability is something that we are certainly striving to achieve. It is not something that we can flip a switch and get overnight. We've come out of the most unstable time in our healthcare system in the last 18 months to 2 years. It has been a huge challenge, something that we had prepared for, but hoped it never happened and hope it wasn't as bad as it was. We're in that point of right now where we see this across Canada. There's a recovery time of the healthcare professionals, and they have been doing an amazing job. We're trying to create that stability. That's why we've had, some investments 4 years ago of more CLXTs into our system, paying for or helping them out with their education to be able to get there. That's why we've invested in more doctors. This is going to take time. And I understand that the people of Saskatchewan have been patient. They've been patient on the primary care side of things. They've also been extremely patient on the surgical side of things. There's people that are waiting for their surgeries. One of the things that we have invested in community care that would be our major investment would be our 2 urgent care centers in Saskatoon and Regina. on Albert Street that you see if you're not from town. It is being built, and the one that we are working on in Saskatoon, we just signed an agreement with the Takakook First Nation to be able to partner with them on some Indigenous healing as well as that. And there's a component to that that is also the mental health and addictions, to make sure that people that are coming in with some mental health and addiction challenges, that they are sought after or be able to seek the medical attention directly that they need. The stability is ultimately what we want. We have, I mean, at the end of the day, we have family members that are on waiting lists. We have friends that are on waiting lists. We have friends and people that I know that are challenged to find a GP in Saskatoon. We want to be able to create that, but it does take some time to build. And what we're doing on our 4-point plan, and not to get too much into that, is we're looking very short term on what can we do short term? Recruit doctors. We've been able to in the last 12 months, considering that things have been very challenging. 12 months ago, we were in a very challenging time where we were having to make decisions to move people out of the province for healthcare, which is not a decision that I ever wanted to have to make. In those 12 months, we've been able to recruit 107 physicians into our province. 51 of them were general practitioners and 56 were specialists. In September, we were able to recruit an additional 23 doctors into the system. Now, only one of them was a family medicine or general practitioner, and the rest were specialists. But doctors are starting to choose Saskatchewan, and there's a multitude of reasons. And if you are talking to your colleagues across the country, please sell the Saskatchewan story. We have a lot to offer here, and it's not always about dollars and cents. It's about work-life balance. But in saying that, we want a stable system too. We really do. And what we're setting out here in our plan and what we've done in the past few years, understanding COVID threw everything off, we're trying to recover and be able to stabilize that system across the province, not just in the major tertiary centers, but in rural and remote areas that Minister Henley we've had some challenges with.
If I could just add just briefly to that, Minister Merriman, on the community care piece, I think that's why it's important why, we're focusing on making sure that we're delivering care and providing support in rural and remote areas of the province, and bringing that healthcare closer to the residents and to the patients, so that they're not always traveling to a Regina or Saskatoon. They get that care in a Swift Current or a Gull Lake, for example, or investments in community paramedicine. Is that an opportunity to expand more, where we have healthcare providers, in this case paramedics, reaching out and meeting the patient where the patient is at. So I think those are all the models that I think we need to be taking a good hard look at in terms of future expansion and having an overall a better healthcare system for everybody, a network, if you will, right across the province.
Thank you. Let's come to microphone number 2, please.
Well, good morning. I'm Lila Cooper. I'm a psychiatrist in Weyburn and a delegate for the Southeast. I really want to applaud the recruitment and retention efforts. At the last delegate meeting, it was brought up about the deficiency for the psychiatry in Saskatoon, Regina, and specifically how the recruitment effort to train people locally and keep them locally has provided some barriers, especially with, as we all know, physician wellness and family issues that even our residents needs to deal with, and accommodating them in Saskatoon, Regina area. However, this has not provided us in areas like North Battleford, Prince Albert, Swift Current, Moose Jaw, Yorkton, with enough psychiatrists. If we look at the emails going frantically around, how bypass is going to happen, and that backlog is putting pressure on the colleagues working in the ER, family physicians sitting in the office the next day, if patients has not been able to see a psychiatrist. So I want to applaud you for the retention and recruitment efforts, but the dilemma we're battling with is not addressing that. Any insights that you can give in collaborating with addictions like Dr. Butt brought up, because we work simultaneously with the patients, and applauding the Estevan rehab unit where psychiatry also has the input. So how do we balance without having these silos and reaching out and making sure there's psychiatry services?
Thanks for the question, Doctor, and for your advocacy on this issue. It's one of our most pressing challenges right now is psychiatry in the province. I think our most recent stats, we have roughly 120 licensed psychiatrists in Saskatchewan. Some of those would be a government-funded psychiatrist, others would be private. But we simply don't have enough. And we don't have enough, and particularly in many communities right across this province. And looking at it as we see the growing demands when it comes to mental health and addictions. We're making record investments into mental health and addictions in the health portfolio, but we're playing catch up, I think. And we need to be able to not only play catch up, but get ahead of it in terms of making sure that we're training enough psychiatrists and psychologists in this province to make sure that we have enough people to provide that support, because these are instances where patients need, when they need that help from a psychiatrist, they need it now. They need to be able to access that support. And we need to make sure that you as a psychiatrist is not overwhelmed by the number of patients and the caseload that you're facing. So it's one of our biggest priorities right now in government. I've tasked our officials and through the SHA and the ministry to do everything and anything we can. We know there's not, it's going to be difficult. There's some of these are medium to long-term solutions. We're doing everything we can to try and recruit more psychiatrists to our province, but they are in high demand everywhere, right across this country. But it's definitely a major priority for us, one of our most pressing challenges when it comes to mental health and addictions. And maybe I'll just ask Tracy, I don't know if you have anything additional to offer in terms of more specifics or details of some of the work that's being done by the ministry to try to advance this.
Sure. Thanks, Minister. So just one of the other sort of points just to add to when we're thinking about stability and we're thinking about the future is that we have struck a new Saskatchewan Healthcare Recruitment Agency as a part of this plan as well, that focus on the future, that focus on ensuring we've got an organization that is looking, including psychiatry, but across all of the professions in terms of the healthcare system. So that was struck. We moved quickly to establish the organization a couple of months ago. And just this week, we have posted for the new CEO of that organization. I'm the board chair of the new Saskatchewan Healthcare Agency, and I can assure you and reinforce what the ministers have said in terms of that focus and the priority around recruitment. It's not just about today, but it's also building for the future and ensuring that we've got good information that's helping to inform what the needs are today across the system, but also where we need them in the future as well. So thank you.
Thank you. Let's come to microphone 1, please.
Thank you. And thank you for your time. I'm Al Beggs, orthopedic surgeon in Regina here. My question is really based around waitlist management. It's a surprise to no one that we're in a huge waitlist surgical backlog, and that steps are being taken right now at the policy level to try and offload. We've heard some of those trickling down with respect to non-hospital surgical facilities and potentially sending patients to other jurisdictions for surgical care. I guess the question that I have is, in these circumstances, we often look to benchmark surgeries as being the only surgeries that really gain the focus of policy, and specifically things like cataracts and hips and knee replacement, cardiac, neonatal, that sort of thing, all completely appropriate for focus. But certainly that represents one finite bucket of surgical diagnoses that are disabling and require access to care. So I was wondering if you could comment somewhat on how government is going to be looking towards the broader diagnoses of surgical, or the broader list of surgical diagnoses, all of which require and need care, which sometimes gets lost in the shuffle when we focus on hips and knees specifically and exclusively, which, while needing to be done, aren't the only things that need to be done.
Thanks very much. And we do absolutely recognize we have focused in on hips and knees for the out of province because those are the ones that were identified to us as the ones that were waiting the longest on the list. Understanding just last week, I was at an event and 2 surgical dentists came up and said, what about us? We've got, we're looking at getting time in the children's hospital. We need kids are on the waiting list. They were pediatric surgical dentists, and they said, we need some time in the operating room too. And we're trying to balance all of that within the SHA. We've asked Andrew and his team to be able to bring up the numbers of surgery, but not just the low-lying fruit, like across all of the surgical wait list. We need to be able to, it would be easy for us to take a lot of the cataracts because we can do a high volume of them, and we're not looking at volume. We understand that with the orthopedics and with other specific surgeries, it's quality of life that we need to get people back to. We need to get them back into rehab. So that's why we are looking at increasing our surgical capacity, both within the SHA and the surgical centers that are publicly funded, that are privately run, to be able to, they just both celebrated their 10-year in Saskatchewan. And I want to say they were in and around 127,000 surgeries that they had done in those two clinics over the last 10 years. They're anxious to be able to complete the surgeries, and we need to get them across the board. So we're trying to attack it more on who's been waiting the longest versus the specific surgery. But there have been a lot of groups, specific surgeons that have come up and said, we want more time. We want to be able to get in there and be able to get our patients recovered. We're also managing that with the support staff that is in around the surgeons to be able to make sure that they have the support staff in there. So we are trying to spread it out as much as we possibly can. As far as the out of province, this was something that was an option. This is not an ideal situation, but people need to have their surgeries done. So are we looking at other things out of the province? Not at this specific moment in time. We want to see how this goes, and then we'll look at other options. But again, this is just to tackle our surgical backlog. So we're trying to get 7,000 more surgeries this year than in 2019, because that's our benchmark. 2020 and 2021 were not good years for the surgical and not good benchmarks. And then an additional on top of that 6,000 surgeries in the following year, and then an additional 5,000 surgeries. That should get us back to where we want, which is under a 6-month waiting list on all surgeries.
Ministers, I'm conscious that we're coming near to the end of the time that.
Are we talking too long?
No, you are absolutely not talking too long. And in fact, I want to address the opposite. I want to respect your time and your busy schedules. Yet I also want to recognize that it is so valuable for the RA to have you in attendance. And I want to get a feel for how you're doing on time. Can we take a couple more questions?
If we want to complete who's lined up at the microphones, we can.
Perhaps we can do that. That is tremendous. If we can complete who's at the microphones right now. Thank you very much. Can I come to microphone 2? Thank you. Please go ahead.
Dr. Dave Letting. I'm a Saskatchewan graduate 55 years ago. I've seen a lot of it. I know what used to work. I know what doesn't work. I'm concerned about all of family medicine, but I want to address rural because that's where I work. I come from an area that is very poorly serviced. I'd like someone to take over for me someday. I know the secret of the whole process is to actually get sustainability. The way to get sustainability is to get Saskatchewan graduates back out into rural areas. When I graduated, I learned extra skills. I went into rural. I didn't just run an office. I delivered a lot of babies, did a lot of surgery. And for me, that was satisfactory. I know there are Saskatchewan graduates that want to do more than work in an office, but we need to give them the opportunity. That isn't available right now. There are very few places where you can learn the extra skills. You can learn how to run an office, but you don't learn how to truly work rural. Other areas have rural medical schools. They have rural streams. We don't have such a thing. In my area right now, you can't even deliver a baby. I'm the old Heartland area. We had a very large area, no regional hospital, but a lot of area of population to serve. Now we have 2 Saskatchewan graduates there, and they're both very long in the tooth. And you tell us you're getting new graduates, but you're not getting not graduates with new physicians, but you're not getting physicians that stay. I know it, and you know it. If you want to get rural docs back out there, you have to give them some satisfaction, and they have to be able to do something. We can't do that right now. So I guess my question is, Have you really looked into the past to see what worked? And how much of that could you reproduce? How many doctors would, I mean, I was raised in Saskatchewan. I have a lot of this. I had
Dr.
the same
Letting,
attitude.
thank you. Your
Thank you.
time's up. We've heard
Yeah.
your question. Ministers?
Thanks, Dr. Letting, and thanks for what you're doing in the former Heartland Health region and as a family physician. It's something that, we've obviously identified is a major concern for us. And it's why we've, as part of the 4-point plan doesn't necessarily specifically address family physicians, but we need to do a better job and provided additional focus onto the whole area of not just training of rural family physicians, but also that recruitment and retention piece. That's part of the reason for the new Health Human Resources Agency. You'll be familiar with the old Sask docs process that we had, which has worked well. But I think given where we're at this day and age in healthcare, it needs some refreshment and revampment, which is why the new Health Human Resources Agency will focus not just on family physicians, but other healthcare professions as well. Yeah, I heard it when I was on my tours this summer, and I visited, I think, close to 30 communities around rural and northern areas of the province, and talking to family physicians as part of those tours in some small rural communities where many like you have been working as a family physician for a number of decades and are nearing the end of their career, and looking at what's the succession plan for you and those patients and those people that live in that community that you currently serve as a family physician. And we've received some good advice from some of those family physicians. Be willing to hear more from you as to not only what's worked in the past, but what do we need to do differently in the future. There's different demands coming from family physicians that are looking to practice. And we also need to take a closer look and do a better job, I think, of not only bringing in more family physicians, but training locally, Saskatchewan born and raised people who are, and there are people that are interested in taking up these practices in rural Saskatchewan, but they need the appropriate support around them. So that's the goal of some of the initiatives that we're undertaking right now, knowing that it's an evolving target, if you will. We're going to be committed to make sure that we continue to do that, so that because if we don't have the proper support and the proper family physician support in rural Saskatchewan, it just simply means more pressure on our urban centers, our Reginas, our Saskatoons, even some of our regional hospitals, so Current, Yorkton, you name it. And so that's why we're focusing on this. But thanks for the advice and the input.
Thank you. To the final 4 people who are at the microphones, out of respect to the minister's time and everyone else's time, if you have a question that you can ask, please ask the question. Try to keep things pretty concise. Thank you for your patience. Can we come to microphone number 3?
Thank you very much for being here, ministers. Thank you to my colleagues. My name is Dr. Carissa Brabant. I am a family physician, hospitalist, opiate agonist therapy doctor. I deliver babies. I am the mother of 2 children, and I own Circle Medical Center in Moose Jaw. The question that I have for you is, the 4-point model does not address the current barriers to being a family physician that owns a clinic. And in order to recruit and retain physicians, you need to understand that the barriers we are facing are primarily business-based. The cost of owning and operating a clinic has gone skyrocketing, and the cost that we get from our patient visits has stayed stagnant. I am not ashamed to admit that it takes $33,000 a month for me to operate my clinic. I get $39 per patient visit. These do not add up. So new grads are looking for places outside of fee-for-service to make money, because fee-for-service is not sustainable in the current model. So my question to you is, what is your ministry doing to support office-based family physicians, especially new grads who are not trained or have experience in business?
Very, very good question. And thanks for your patience again of standing over there.
Yeah.
Appreciate it. You've raised quite a few good questions on what it is to manage a business and to be able to be a clinician. And those are certainly, you're juggling an absolute, a lot of things right there. What I'd like to do is be able to, maybe, can I chat with you after about some of the challenges?
I would love to.
Yeah, I'd like to be able to find out exactly what some of the specifics are, but in general, the fee for service is really good for some physicians, some other like the salary. I've heard that a lot of graduates, when they're coming out, they want to be on a salary. It's something that, they don't have to worry about the bookkeeping. They don't have to worry about any of the administrative stuff. They can go in, do their work, go home.
And if I could comment on that, it also allows us to provide more complex care.
Yes.
For example, an addictions patient who needs that continuity of care after they have reached that level of sustained recovery, as Dr. Butt said, perfect for family medicine.
Yeah, and that's what we're looking at. And when I attended the white coat ceremony just a few weeks ago, and then had the postgraduate medical educators, that was one of the things that came up is we don't really want to be on fee for service. Okay, get that. How can we get you on salary? What is it that's going to work for you specifically? Because we want to retain you, we want to keep you, but understanding that we don't want to burden you and overload you. You're coming into a system that's got lots of challenges right now. We don't want to overload you with something else that's going to make you turn you off of that profession. So we can certainly work with more salaried positions and more fee for service, depending on the individual. But it certainly, we would be more than open to doing that.
Thank you. I'm about to come over to microphone number 1, but I want to point out something I've been noticing during this session is that people asking questions are wanting to follow up with the minister and engage in a conversation. And I think that's a great sign of your openness to engage in that conversation. Of course, it makes my job harder. So guys, can we come over to microphone 1?
Thanks very much. So I'm Ben Leese. I'm the chair of the internal medicine section, and I'm an internist, and I also do cardiology in Saskatoon. Can you hear me okay?
Yeah, I can't hear you.
I'm not sure how to, oh, there we go. Is that better?
Yes, sir.
So yeah, there's a lot of themes, particularly around addictions and vulnerable populations, and that driving a lot of the work that we see not only in the community, but also in hospitals. One of the things driving burnout in internal medicine is trying to deliver care in, I guess for lack of a better term, a broken system, or ways where we see what the patient needs, but we can't actually deliver it because of barriers with regards to addiction support, barriers with regard to hospital beds, et cetera. Now, a lot of us have great ideas about this. And in fact, Sanctum Care Group in Saskatoon has really revolutionized, for example, the care in HIV. We think this model is generalizable to lots of different medical conditions. Because I'm a cardiologist by training, I've been very interested in endocarditis. And of course, it breaks our heart every time someone leaves against medical advice for treatment in endocarditis because they're being stigmatized in hospital. And family doctors are expected to pick up the pieces of these broken plans and try to save these people's lives, right? A lot of them die in their 30s and 40s. So this bothers us a lot and obviously drives burnout. And yes, it would help to have maybe more people, but what we really need is innovative care. And so Sanctum Care Group has not only led us, on this course to pick diseases and try to create comprehensive models of care, but I have in my hands a proposal around endocarditis, which is a rising epidemic in Saskatoon and all communities across Saskatchewan. So I wanted to take this opportunity to beg you to take this with you today and to review it. And then of course, you'll hear from me through official. And we're all really excited about it, internal medicine. And so I hope that perhaps the ministry in the future could create a rapid access, maybe committee, to see some of these grassroots initiatives in real time and get things moving, because we're excited to be in this province and we want to lead the country supporting these patients.
Before the ministers respond to that, I want to say to the 2 people waiting at the microphones, this is your opportunity to winnow down your questions. It's on me. I've let things go over time. You're going to have 30 seconds to ask your question. Ministers, would you like to address Dr. Leese?
Thanks very much for that. And I'm very supportive of Sanctum and what they are doing, because they've been doing an amazing job. Caitlin's been doing a fantastic job there, and a very innovative way of dealing with people that have challenges. I've toured Sanctum multiple times. When Minister Ryder was Minister of Health and I was Social Services, we did tour. We were at the grand opening. Amazing model of care. And I can't thank Caitlin enough, and her team and the board, and Peter, who's here as well, who is also being able to wrap themselves around those individuals that need a lot of care and be able to keep mom and babe united. And that's a huge step forward. I'd be more than happy to look at your proposal and get my officials to do an assessment and bring it up at one of our briefings in the near future to be able to see if there's something that we could work on. So, and thanks for your work with Sanctum, a great organization.
And we've also got, Paul, I think we've got a meeting coming up with Sanctum Action in a couple of weeks with myself, Minister Merriman, and I believe Minister Mikowski as well. I had a chance, myself and Minister Mikowski toured it in June, but yeah, we have a meeting in a couple of weeks, so I think we'll be getting into some of these details.
Thank you.
Thank you. We'll come to microphone number 2. You have 30 seconds.
Yeah. Thank you very much, Mr. Speaker, and welcome both Ministers for Health. My name is Dr. John Marco Pondo. I'm a medical health officer in Saskatoon, but also the chair of the public health section of the SMA. I will just be very specific, looking at the time. You know, you may not have received a particular proposal, but the last 2 questions really set this up well for alternate models, particularly in public health. So for syphilis and addictions, you know, we're really looking at innovative practices.
Dr. Pondo, I do apologize. This is on me. Can you ask your question? Please?
Yeah, my question is, disease investigation specialists who are not necessarily licensed providers and care navigators, which are both programs that have been tried at a pilot basis. These are things that I think public health can bring to improve access to care. And I'm just wondering if this is something that we should try and find a way of bringing forward to both your attentions.
Absolutely. It's something that we'll have a conversation with Dr. Shahab about it. I see Rebecca's over here from the ministry as well, who's in charge of public health for our ministry. We'll certainly have a look at that to see if there's some opportunities there, sir.
Thank you very much.
Thank you.
Thank you. Please, 30 seconds at microphone 2.
Donna Lettingham, I'm a pathologist and a delegate from the Regina RA. To make a long story short, I think we can all agree that e-health is currently meeting the needs of the SHA very poorly, if at all at times. And I was wondering if the government could commit to ensuring that e-health has an accountability agreement with specific timelines to ensure that projects are completed in a timely manner. And if not, that external resources are engaged.
Thank you very much for that. Yeah, there has been some challenges with eHealth. There's no doubt about that. We've had a security breach. I believe it was about 1.5 years ago. We've had some challenges. We have had some more investments come out in our budget and in term to be able to shore up eHealth. Are we exactly where we want to be? No, but we're getting there. We're making some improvements on a go forward basis. But with the e-health and with the technology, it's always changing. And this was also something that Minister Henley and I heard when our tours around, is that there are some challenges with e-health, and Tracy and her team are certainly going to work on that and allocate some more dollars in our budget to be able to work with e-health. We have to go through our budgetary process, but we recognize there are challenges there. And I know it creates some unnecessary frustrations.
Yeah, I mean, an instrument sat on a bench in St. Paul's Hospital for 18 months and an external contractor had it connected in less than a month. So I think there needs to be some accountability, respectfully, but thank you, Minister, for your response and your time.
Thank you.
Thank you to all of you for your questions, and special thanks to the ministers and ministry staff for taking time out of your busy schedules to join us today. Thank you very much.